Greetings, Patho students, and welcome to week 10. You should have already completed your exam number 3. If you have not taken course exam 3, stop listening to this, go check your calendar, and if there's still time, you need to take exam number 3. For week 10, we're covering the neuro system, the nervous system, or the neurological system, as well as Unit 11, genitourinary and reproductive function. And the good news is for this week, I'm going to knock out chapter 38 right off the bat. So the first chapter we're going to look at is chapter 34, which is the organization and control of the nervous system or neural function. But I want you to know as we get into all of these chapters, listen to what I'm saying. Look at what I'm pointing you towards, read what I'm pointing you towards, and we are going to be overlooking quite a lot. The nervous system obviously is the brain and spinal cord, very complex system in our body, as you know, certainly the endocrine system and the cardiovascular system are also complex, but the neurological system is extremely complex. And there is a lot that we're just going to fly over. I'm going to focus you in on the most important points and that knowledge and content that nurses need to know as they safely care for patients. And I know you're on your way to become those nurses. So I want you to listen to what I'm saying here and don't get overwhelmed by all of this very complex content. So in chapter 34, obviously I want you to be able to differentiate between the central and the peripheral nervous system. We think of the central nervous system as the brain and the spinal cord, and the peripheral nervous system as comprised of the cranial and spinal nerves. And it is that peripheral nervous system that we reference the sympathetic and the parasympathetic nerve fibers. That's part of our autonomic nervous system, the sympathetic and the parasympathetic. Obviously, you've heard us talk about that before in anatomy and physiology. You overviewed those two components of the autonomic nervous system. If you like, you can take a look at the video that's called Nerve Synapse video. It's short and it will kind of give you an overview of some of the unique functions of the cells that comprise the nervous system. That is the neurons and the neuroglial cells, we call them. They both transmit and receive electrical and chemical stimulation. Go down through that chapter 34 quite a bit and take a look at the table 34-1, which overviews the cranial nerves and the spinal nerves and what are their function. So I want you to read a little bit about the spinal cord and its functions. Take a look at that table. Figures 34:11 and 34:12 will help you put those two in perspective. Moving right along, we're just looking at the overview of the system in this chapter, the functions of the brain, and take a look at figure 34-14. Related to the functions of the brain. Be able to differentiate some components like the meninges. Take a look at figure 34-18 and then also 34-16 related to the lobes of the brain and the actual functions that are related to specific locations of the brain or specific lobes. Read about the function of cerebrospinal fluid, CSF. Cerebrospinal fluid, why is that so important to the brain? And then also read about two important concepts, the blood-brain barrier and the CSF brain barrier. In teaching pharmacology, this is really important that students understand that blood-brain barrier. I kind of teach that there is a lipid layer over the brain. I think of it as, I don't know if you're old enough to know what Crisco is. I think you can still buy it today. People use it for baking. Some people do. I think it's a relative of lard actually, but it comes in a can and it's white. Imagine this lipid layer encasing the brain. which is the blood-brain barrier, which makes it impervious to substances that are not lipophilic. Medications that pass the blood-brain barrier must be lipophilic. The other category is those medications that are hydrophilic. So those are medications that cannot penetrate the blood-brain barrier. And know that there are many medications that we do not want to penetrate the blood-brain barrier. So that is a component of research that goes into the R&D of all new pharmacological drugs, and whether or not they will cross the blood-brain barrier, whether we want them to cross the blood-brain barrier, because some of them have bad effects if they get across that barrier. So I want you to be familiar with the blood-brain barrier and also the cerebrospinal fluid brain barrier as well, and take a look at figure 34-21 related to that. I already mentioned the autonomic nervous system. If you take a look at figure 34-22, it'll give you an overview of the sympathetic and the parasympathetic. Under normal circumstances, they oppose each other, but they do work in concert when there is a balance between the sympathetic and the parasympathetic side. Okay, moving on to chapter 35, which is somatosensory function, pain, and headache. The focus here is going to be on pain. So we're going to skip over some of the areas at the front of the chapter. I do want you to read about tactile, thermal, and position sense modalities. How do we get impulses? How do we get information to the brain about that which we can feel, the temperature of something externally, and the position that our body is in, for instance. And then we're going to dive into pain, differentiate the mechanisms of pain sensation, and then the different types of pain: cutaneous, deep somatic, visceral, and referred pain. There's a diagram, 35-10, which helps you understand about referred pain, and much cardiac pain is actually referred pain. So do read about the mechanisms of referred pain. I'd like you to differentiate between acute and chronic pain. Take a look at table 35-1. And then we're introduced to pain management. How is pain managed from a medical perspective? I can tell you from a nursing perspective, it is the patient that defines pain. If a patient tells us that they are experiencing pain of 10 on a 0 to 10 scale, then we take that at face value. We don't try to second guess the level of pain that our patient is experiencing. In this section, you can read about non-pharmacological pain interventions and treatments, as well as pharmacological pain interventions. And there's an overview of narcotic and opioid analgesics and how they affect a patient's pain. There's also a short section about surgical intervention that we can use in some cases to relieve a patient's pain. And then I do want you to understand the nature of neuropathic pain. What are the causes and characteristics and interventions for neuropathic pain? Then finishing up this chapter with a focus on migraine headaches. And that's about all I want you to hit in this chapter. Moving on to chapter 36, which is disorders of neuromuscular function. First of all, take a look at the glossary at the head of this chapter, because there are some words here that will become part of your nursing language that you need to be familiar with. And then understand what are the unique contributions of the spinal cord, the brainstem, the motor cortex, the cerebellum, and the basal ganglia. How are they organized? Related to our ability to move, the body's ability to move. And there are some examples of how those affect skeletal muscle, for instance, in figure 36-3. I'd like you to be able to differentiate spinal reflexes, like what is the definition of spinal reflexes and how do we assess those? And then how do we assess motor function, the body's ability to actually move? There is a figure 36-4 that will describe graphically how the words we attribute to loss of function. And that would be when a patient cannot use a portion of their body. What are the proper words, the proper terminology we use to describe loss of function? Moving on, I'd like you to be able to differentiate disuse and degenerative atrophy. You probably already know the word atrophy, but here we have two distinctions. There is disuse atrophy, there is degenerative atrophy, and I'd like you to know the difference. I'm going to overview for you now what are the specific disorders that I'd like you to hit in this chapter. One is muscular dystrophy. Another is simple back pain. There's a large section of this chapter dedicated to back pain. Back pain is a common admission diagnosis for patients, and it is something that a patient is worked up for, back pain, to determine what is the nature and origin of it and what kind of interventions are going to be effective, hopefully, for that patient. So take a look at figures 36-9 and 36-10 related to the causes and descriptions of back pain. Then we're moving on to some other disorders of the brain, the cerebellum and the basal ganglia. And I want you to read about Parkinson's disease. What are the causes? What is the exact pathophysiology of Parkinson's? How do we make the diagnosis? And then what treatments might be effective for Parkinson's disease? Take a look at figure 36-12. Moving on to specific disorders of the motor neurons. One is ALS. That is also known as Lou Gehrig's disease. That is amyotrophic lateral sclerosis. Another disorder is multiple sclerosis, MS. So I want you to read about those two disorders distinctly. Take a look at figure 36-13. Moving on, I want you to do an overview of spinal cord injury. In figure 36-14, that is specific, I believe, to compression injury. One example of spinal cord injury. Moving on to figures 36-15 through 17 for other types of spinal cord injury. And how does spinal cord injury affect motor and somatosensory function? How does it affect the autonomic nervous system? Really, a spinal cord injury can have a global effect on the body. It can affect the bowel and bladder. It can affect sexual function. It can affect respiratory function. It can affect temperature regulation, edema, skin integrity. So there's a lot that can be attributed to injuries in certain areas of the spinal cord. So take a look at table 36-2 related to all the trauma that can be experienced via a spinal cord injury. 37, which is disorders of brain function. Again, take a look at the glossary for some new terms or review of some terms that you may already understand. And the mechanisms of brain injury. How are the different ways that our brain can be injured? I want to say a global issue related to brain injury is cerebral edema. Become a precursor for increased intracranial pressure, which could become a precursor for brain herniation. So three concepts here: cerebral edema, increased intracranial pressure, and brain herniation. Bad, bad, bad. All of those are very bad. So I want you to be able to distinguish between those three terms and then have an idea of what's going on in the brain as the brain progresses all the way towards herniation. There is a term in here that is related, which is hydrocephalus. We usually think of this as water or fluid on the brain, too much water, hydrocephalus. And then we're going to get into actual brain injuries, primary and secondary brain injuries and head trauma. And there are some diagrams here. Figure 37-6, for instance, is an example of, they don't use this term, I don't believe, but we also call it coup contra coup injury, where there is a blow, let's say, to the frontal area of a direct blow, like a head going into a windshield. So you have a unrestrained passenger in a motor vehicle accident, head into windshield. The initial blow to the front where the head comes in contact with the windshield is the primary injury. And then as the head is thrown backwards, whether or not it's thrown into the seat or not, you know that the brain is just floating like jello within the skull, within its enclosure. So the primary blow is to the frontal, but there is a rebound then as that chunk of jello goes flying back, and there's actually damage to the back of the head. So this is the coup, the blow, the coup, and then the contra coup, which is the reverb as that the mass of your brain then is whipped to the back of the skull and also sustains injury. So that's an interesting phenomenon, and in this section I want you to read about brain contusions, hematomas, and concussions, specifically concussion syndrome. And then moving on, what is the locations of hematomas, where there's actually blood collecting in the brain, sometimes from injury, but sometimes from some other pathology where vessels have just broken. And take a look at figure 37-7. You'll also read about post-concussion syndrome, CTE, chronic traumatic encephalopathy. And those are things that I'm kind of interested in because I love the NFL, and I've just been paying attention to various players throughout the league over the years and the progress that hopefully the league will continue to make related to protecting their players from traumatic brain injury. If you've never seen the movie Concussion with Will Smith, if you like stuff like that, like I'm kind of geeky, related to medical-based real stories. This is the real story of how the pathologist first discovered microscopically the damage from repeated concussions from football players. So it was the brains of football players that helped us to come up with this diagnosis of CTE. So take a look at that, read about it, it's very interesting. And of course, where are the locations that hematomas can occur in the brain? And then how do we assess consciousness? How do we assess for levels of consciousness and then when there is injury? So take a look at tables 37-2 and then 37-3 is actually a depiction of the Glasgow Coma Scale. We use this in the field, in pre-hospital care, also in the emergency room. We use it in the ICU as a very simple measure of 3 factors that tells us a little bit about the patient's neuro-functioning. And one is the ability to open the eyes on command. What is the best motor response we can elicit from a patient on command? And then what is the best verbal response we can elicit from a patient on command? So take a look at that scale. It's 0 through 15. Then move on to other disorders related to cerebral vascular system. And this has to do with bleeding. Bleeding and then deprivation of oxygen to parts of the brain. So I want you to be able to explain and recognize the difference between an ischemic stroke versus a hemorrhagic stroke. So previously I asked you to differentiate between the hypoxic brain injury and the ischemic brain injury. So when you have an ischemic brain injury, well, you'll see. There's a video in here that I want you to watch. It's just called Stroke. And in that stroke video, they do explain the two. It's a little longer than most of the videos that are in this ebook, but they do explain the 2 different types. The ischemic stroke and what are the causes of that, what happens to the brain, and then the hemorrhagic stroke. Also, what are the causes, and then what is the outcome to the brain. Because they can present with similar signs and symptoms, we need to know clinically which of those two kinds the patient is having, because the treatment for instance, an ischemic stroke, if we give that treatment, which is TPA, intravenous TPA, within the first 4 hours of the onset of signs and symptoms, if we give that treatment to a patient who's having a hemorrhagic stroke, we can kill them. So all stroke patients need to have a head scan, a CT scan, before we can determine what treatment pathway will best help them. That's just an important distinction, and that's why we make such a big deal about the diagnosis of which kind of stroke a patient is having. Because to look at the patient, we cannot tell. We need to have imaging of their brain in order to tell. So also take a look at table 37-5, which relates signs and symptoms of a stroke related to the location or the lobe or the area of the brain that's being affected. It's difficult to assess a lot of this information by simply examining or assessing the patient. This is why we rely so heavily on brain imaging for these patients. Moving on, differentiate the various types of intracranial hemorrhage. What is a subarachnoid hemorrhage? Where is that exactly located? And then some disease entities, the difference between meningitis and encephalitis. Meningitis, we have both bacterial and viral versions of meningitis. Take a look at figure 37-17. Moving on to brain tumors. This is probably the best example of a space-occupying lesion. And that is the issue with a lot of problems that we have with the brain. Obviously, bleeding alone can become a space-occupying problem, where there is pressure placed on brain tissue within this confined space, and it leads to brain swelling, edema, increased intracranial pressure, etc. But back related to brain tumors, you need to know the difference between benign and malignant brain tumors. Even a benign tumor, which sounds not so bad, if it is space-occupying significant, it can cause some life-threatening issues, and the patient needs to have surgery to have even that benign tumor removed. What are the clinical manifestations of brain tumors? What do patients look like as they are developing brain tumors? What gives us our first clue, or gives the patient a clue that this could be going on within their brain? Moving on to seizure disorders. The difference between a seizure, a convulsion, and epilepsy. Moving on to the neurocognitive disorders. Terms I'd like you to differentiate: memory, cognition, and dementia. There is a great video here called Alzheimer's. It's inserted in your e-text. So I do want you to take a look at that video, the Alzheimer's video, with a focus for these neurocognitive disorders on Alzheimer's, because that is probably the most prevalent of all of these dementias. And then just for interest, take a look at figure 37-18, which is an example of a PET scan. PET scan is positive emission tomography, I believe. PET scan. Of course, we abbreviate it for a reason. But it's the colorful imaging that we get that actually shows perfusion of the lobes of the brain. So you'll see a PET scan of a normal brain, and then the PET scan of a patient who has Alzheimer's. And you can appreciate the difference and what that difference will mean in relation to that patient's function. So that is the end of chapter 37. We're going to omit chapter 38. It is unit 11 in your ebook. It is genitourinary and reproductive function, covering chapters 39, 40, and 41. And you'll be happy when you hear what I want you to focus on and what I will ask you to overlook in those chapters. We only have 2 more weeks after this week of content, and then we have our course 4 exam and the final. If any of you have concerns about your grade and how it's averaging out, you should be able to see a percentage over on the far side of your gradebook in Canvas. And that is your percentage that you've achieved for the points that have been available to you so far. So if any of you are landing under the 70% mark or dangerously around the 70% mark, and you want to send out an email to me about what you need to be doing to ensure your success in this program, in this course with a passing grade. And I'll tell you right now how I'm going to respond. I'm going to ask you about some activities that you've been doing within the course. For instance, have you been watching the focus videos every week? Have you been doing chapter prep you quizzes? I just finished inputting the grades for the third course exam, and when I go in there I can see all of the student activity for Prep U, and I have to say that in most cases the students that are getting the high grades on those exams are the ones that are also doing lots of activity within Prep U. And those who are struggling with their exam scores seem to be doing no extra Prep U quizzes. So I think that might be part of a recipe for success. It's not too late. Don't forget that after your course 4 exam, which will be on just the most recent content, you're also going to have a final exam. Final exam is 75 questions on all course material. So it's never too late to be getting into Prep U and taking some of those self-exams. Also, a reminder that you have your last case study 5, which is on sexually transmitted infections, or STDs as we call them. Now the lingo is STIs, for sexually transmitted infection, which is what they really are, is infections. So you have your last case study. I'll tell you right now, it's on syphilis. Sometimes if you read through the whole case study, at the end you actually might have a clearer picture of what it's about. So do read through. I would encourage you to read through the whole case study before you start to respond to the individual questions, because that will get you more focused on which direction this patient is going. So let's get into Chapter 39, Disorders of the Male Genitourinary System. And if you start out in Chapter 39, you'll see it starts with a figure 39-1, which overviews the structures of the male anatomy, basically the testes, the scrotum, the genital ducts, the accessory organs, and the penis, their location and function. Take a look at that figure. And then also do look at the table 39-1, or I think it's labeled chart 39-1, about the functions of testosterone, which is the primary male hormone that it relates to reproductive and sexual function in the male. Then you drop all the way down. There's a lot of disorders that are coming up in this chapter that we're going to breeze over. My focus is to narrow it down to some of those disorders that are clinically relevant, meaning we're not preparing you to work in a doctor's office necessarily or work in a urologist's office, but to be nurses in a hospital setting. And we're going to focus on the disorders that we are more likely to see in a hospital setting. And one of those disorders is priapism. That'll be further into the chapter when you're looking at disorders related to the penis. That is a continuous erection lasting greater than 4 hours. That is considered a medical emergency. And should that happen, it can happen to people of all ages. It can happen to children as well as adults. Sometimes it is in correlation with the patient taking erectile dysfunction medication. But no matter the cause, it is considered an emergency because it is a vascular situation in the penis that can result in tissue damage if it's not treated. So any erection lasting greater than 4 hours, that patient needs to be transported to the emergency room for some intervention. Then go all the way down. You can skip over disorders of scrotum and testes, go all the way down to disorders of the prostate. This is what brings a lot of people into a hospital setting both from a medical perspective as well as a surgical perspective. So I do want you to read about acute bacterial prostatitis, and then your big focus in this area is going to be on benign prostatic hypertrophy, or hyperplasia as your book calls it, BPH. And this is sometimes considered a precursor for prostate cancer, which of course is a huge concern for most males of a certain age. But BPH is common enough that they say 50-year-olds, about 50% of 50-year-olds will have BPH, about 60% of 60-year-olds, 70% of 70-year-olds. So as you advance in age, more likely you are to have issues with, basically it's an enlarged prostate. And why that becomes an issue is the prostate, you'll see in the diagrams, if you look at figures 39-11 and 39-12, the prostate encircles the urethra. So the enlargement of the prostate then becomes a problem for the urinary tract and the patient's ability to empty their bladder, which becomes a huge, big problem. Then also I do want you to read, so I want you to read everything there is in the book about BPH, and then also move on to prostate cancer and look at figure 39-12. Read about what are the clinical features, how do we screen, because as a nurse you're going to become an authority on when should some of these screenings take place, at what age, and what are the expected findings. So do read about the screening for prostate cancer, how we make that diagnosis, and then what is the relationship between prostate cancer and BPH. That's it for the chapter on male. Now let's move to female. Female, there's a few more disorders we're going to take a look at, but you'll start with the structure and function of the female reproductive system, and that's figures 40-1 and 40-2. Take a look at the graphic of the uterus. Know that there are 3 layers to the uterus. And also take a look at the ovaries and the functions of the ovaries, looking at figure 40-4. Then just like I want you to know what are the functions of testosterone, I also want you to look at the table about the functions of the female side, which is estrogen and progesterone. And that is table 40-1. And we're going to skip over a few things and we'll go on to cervical cancer. And that is all the way on to page 1029. So read about the causes, the pathology, the prevention of cervical cancer, how do we make that diagnosis, and how is it treated. Another female disorder we want to look at here is PID, pelvic inflammatory disease. Take a look at figure 40-9. Another disorder, endometriosis. Endometriosis. You can skip over endometriitis. You can look at it if you like. But the big one I want you to look at is endometriosis. And there's figures 40-10 that talk about all the different locations that endometriosis can land and why this is an important disorder. What are the siliquae of endometriosis? Then reading further down to page 1033, what happens when the pelvic floor starts to fail? There are all these female organs, the bladder, the uterus, the rectum, etc., all kind of balancing on the ligaments of the pelvic floor. What happens when the pelvic floor starts to fail? So I do want you to read about those disorders of cystocele, rectocele, enterocele, and uterine prolapse. And if you look at figure 40-13b, you'll see the locations of all those problems and the surgical interventions that are required in most cases. Then moving on, a couple more disorders. One is ovarian cancer. What is the incidence, the types, the risk factors for ovarian cancer? How is that diagnosed? What's the clinical presentation? Because the ovaries cannot really be visualized typically during any kind of an exam, this is a very difficult cancer to catch, and therefore I believe the mortality does go up slightly with ovarian cancer. That's on page 1036, and so take a look at figure 40-16 related to ovarian cancer. Then we'll move on to staying in female, the disorder of breasts and breast cancer, the risk factors for breast cancer. The reason I focus on some of these is this is what nurses are expected to know related to patient teaching. Like, how do you teach a patient, male or female, how to screen for some of these disorders? How can they be responsible for their own sexual health? So what are the risk factors for breast cancer and the importance of breast exam? And what are the recommendations for mammography, which is currently our kind of gold standard as far as diagnosing breast cancer? And that is on page 1044. Take a look at figure 40-19 for information that you'll be responsible for related to breast cancer. That's it for our females. Now we're going on to sexually transmitted infections or diseases. And there are many of these. We're going to focus on a few. The biggest ones, the main ones that we tend to see and that people need to know about. We start out chapter 41 with a discussion on page 1050 of HPV, human papillomavirus. 360 million people, in the country, in our country, just our country, are the carriers of HPV. So read about HPV and what kind of a risk factor that is, how is it diagnosed. We now know there's a vaccine, obviously, for over a decade now we've had a vaccine that is effective against most strains of HPV. So take a look at that. Inform yourself if you don't already know. You're going to be a nurse, so people are going to expect that you'll have current and proper information about HPV and that vaccine. Moving on to genital herpes, as it relates to herpes simplex virus, you'll read that there are two, herpes simplex 1, herpes simplex 2, and we used to think of only one kind of herpes simplex as the genital herpes variety, but now we know that both varieties of herpes simplex can actually cross over and become related to our sexual organs. Yeast infections, candidiasis, I'm not sure if I'm pronouncing that, but it's related to candida. And we think of that as a secondary infection very often when females are put on antibiotics for any various reason. They will, within a few days, develop a yeast infection. Sometimes it is candidiasis. So do read about that so you'll understand how a patient is diagnosed with it, what predisposes them to it, and then what kind of intervention we do for that particular disorder. And then we're going to close off this chapter with the big three: chlamydia, gonorrhea, and syphilis. And those have been around for a long, long time. And unfortunately, they're still out there, and people do still get them. And most of these sexually transmitted diseases can be eradicated to some extent by practicing safe sex or by using protection during sex. So take a look at that and think of yourself as a kind of a public service announcement for some of these disorders that you as a nurse should have, again, current and correct information and be able to inform your patients on how to protect themselves and then what to do should these symptoms occur. For this, I'd like you to look at figures 41-6 and 41-7. This chapter in particular, 41, is full of some very gross pictures. Usually we see graphics, and there are some interesting graphics in this chapter, as well as actual photos of various sexually transmitted diseases. Those are gross to look at, but once you take a look at them, they'll make an impression. It'll help you inform your patients, I think. So let me know if you have any questions about these chapters. Don't forget you have that final case study due on sexually transmitted. I'll be back with you next week. Thanks.